I'm a vascular endovascular surgeon. I work at the Harley Street Heart and Vascular Center, which is based at Gleneagles and Mount Elizabeth hospitals. And I also work at the Venous Clinic at Camden Medical Center, which is a center that is dedicated to the management of pelvic congestion syndrome. My special interest in vascular surgery has been the management of superficial and deep vein disease, which is where the interest in pelvic congestion comes from. Pelvic venous disorders are essentially a problem created because we have adopted the upright posture. And in doing so, we have created two problems. Firstly, as the veins leave the leg and move towards the heart, there is a compression of these veins at the level of the pelvis. So there's a high pressure created near the pelvis, and the veins tend to pool, the blood tends to pool in the veins around the pelvis. Pelvic congestion syndrome is a problem related to varicose veins in the pelvis. The other problem that we created was a compression at the level of the vein that leaves the kidney and crosses over from the left side to the right side. So this leads to back pressure down the ovarian vein, and again varicose veins around the uterus, the pelvis, the ovaries and the vagina, leading to the symptoms of pelvic congestion syndrome. Understandably, those who have multiple pregnancies where the ovarian veins are dilated, they tend to have more of this problem, but we are also seeing this in women who've had multiple cycles of IVF. There can be heavy bleeding, some of them have low back pain. Many of them come with symptoms of painful intercourse, especially pain that lasts after intercourse. There can be heaviness in the region of the legs, especially around the time of the period. And these are all symptoms of engorgement of the pelvic veins that occurs with this condition. So the diagnosis can be difficult. The key is to make sure that there is a diagnosis of the functional condition, and the gold standard really should be a trans-abdominal, trans-vaginal duplex examination. By duplex, you mean an ultrasound of the solid organ as well as an ultrasound of the blood vessels. Many people would find that they are diagnosed based on CT scans and MRIs. This is really insufficient because you don't get a functional diagnosis, you only get an anatomical diagnosis with those investigations. No, all patients certainly don't need an operation and certainly shouldn't be offered an operation to start with. Most patients can be managed conservatively, but this has to be done as a team effort with a combination of pelvic physiotherapy, medication, sometimes some painkillers and psychological support. But those whose condition is more severe, then the treatment is to try to reduce the degree of pelvic hypertension by either ovarian vein embolization, if that is the source of the problem, or by iliac vein stenting, if that is the source of the problem. But in nearly all patients, you are going to need a combination of physiotherapy as well as venotonic drugs like Daflon in order to make sure that there is supportive care for them.